Hello, I'm Megan Young, UM manager and host of Tech Med Talk, where we explore the latest advancements in healthcare technology with industry professionals. Today we are diving into the topic of the origins and evolution of case management in order to provide essential insights for hospital executives on the value and shortcomings of inpatient and insurer case management. Joining us once again is Rachel Phillips, RN, BSN, the founder of Med-Rok Systems, to discuss a history and evolution of case management, its impact on hospitals, financial successes, and case management IT solutions. Welcome back, Rachel. Thank you for continuing our Tech Med conversations.
Good afternoon, Megan. I'm excited to shed light on this critical topic and its financial implications for hospitals, physicians, insurers, and healthcare consumers, which I believe many healthcare executives may not be fully aware of. And also I'm looking forward to discussing the technological solutions that our industry can benefit from in addressing these challenges.
Let's start, Rachel, by exploring the origins of case management.
Well, case management has been practiced since the early 1900s, with the earliest case managers being public health nurses and social workers who coordinated services through the public health sector. Following World War II, insurance companies began to employ case managers to assist with the coordination of care of soldiers returning from war who suffered complex injuries, requiring multidisciplinary interventions. The current evolution of formalized case management began actually with Medicaid and Medicare projects in the early 1970s. These programs usually employed a social worker to arrange for and coordinate services to clients in categorically defined groups such as low income, mentally ill, and the frail elderly. So initially, hospitals actually introduced case managers to coordinate clinical care among multiple specialties of physicians and ancillary services in response to rising demands for improved quality and cost-effective health care. However, with the introduction of insurance companies and as the landscape evolved, the focus of hospital case managers shifted more towards the financial aspects, spending most of their time reviewing clinical data for insurer payment approvals, contesting denials, which caused a realignment, and in my opinion, not in a good way, away from clinical coordination with the healthcare team and working with patients and families, especially during the discharge planning.
So you're saying that the value of case management has been diminished by pivoting from clinical to financial? Can you elaborate on that?
Well, experienced case managers attempt, and I'll say often unsuccessfully, to do justice to both clinical and financial concerns, in addition to providing care for the patient and their families. But for some time, and currently, so many hospitals are so concerned about sending reviews to insurance companies to avoid denials, their case managers have lost their clinical and healthcare team coordination skills, which is really where hospitals avoid unnecessary financial costs and losses. Yes, having also been an insurer case manager, I can tell you that we don't even read those reviews that the hospital case manager sits for 8 hours on 28 to 30 patients typing up. We as insurer case managers resort to the raw medical records to create our own reviews. So this is just an example of how our healthcare industry tries to solve problems, which is just throwing more people and more money at it. And what I mean by that is taking insurer and hospital case managers out of the equation. The simplest, most primary solution to this clinical issue, or making sure a patient meets medical necessity to remain inpatient and avoid insurer denials, is to educate the bedside nurses along with the hospital physicians regarding industry standards such as Milliman's or Interpol, which is what the insurers use to either question or deny, approve, question, or deny the patient's ongoing inpatient care. So, which, they're very capable of doing that, the bedside nurse and the physician. But unfortunately, that education has not taken place to this day. Instead, hospitals hire more and more case managers and hospitalists to protect their losses, and I must say ineffectively, which at the same time insurers hired their own case managers and physician reviewers to protect their costs, all the while increasing the total cost and waste. And if you remember, I think in our first talk, I told you that over 35% of the over $4 trillion in U.S. healthcare cost is administrative. And that part about the insurance authorizations is pretty much administrative or a necessary administrative cost. Also, just wanted to say on the other side, as the insurer case manager, and I've done both, hospital, insurer, post-acutes, etc., being on the other side, which physicians call the dark side, it emotionally and physically hurts me to review case after case of a patient sitting in the hospital for 2 to 3 days, sometimes over 2 to 3 weeks, that don't have any inpatient issues, and to have to deny them. It's almost like I'm screaming inside at whoever the hospital case manager is, go inform your physician that the patient may need lower level of care and discharge. So on a daily basis, it can be millions of dollars I'm witnessing being drained from the hospital, and worried that the patient will be billed without knowing why.
Wow, well, this makes me think of the conversations we've had in the past of case management neglecting clinical duties, of which one case was inpatient over 280 days with over 1.5 million in denials. Would you please share that case to illustrate the value of clinical case management?
I would be delighted. And I'll just set up the scenario. I was actually working as a contract hospital case manager at a small 150-bed community hospital in Los Angeles. And when my first day there, I got a look at the census and noticed that for such a small hospital, they had over 35 cases with a length of stay anywhere from 35 days to 280 days. And at that point, I did approach their director, and, having done that and had a business before where the goal was to problem solve those discharge barriers, I asked her to go ahead and on a daily basis just assign me those 35 cases. So the case you're talking about, one of those cases was a younger patient who had some anoxic brain damage. He was ventilator trached and ventilator dependent. And they had been trying to get him into a subacute for months. So the first, and I'll just illustrate, this is a little bit of clinical case management in that, I noticed he was on 70% FiO2 on the ventilator. And also that he was getting blood transfusions every 3 days. He did happen to be on dialysis, I will say too. So when I got a hold of the case, again, I do a complete review and I pull out those discharge barriers. So I went to the pulmonologist and explained the situation and said, this is why he can't be transferred to lower level of care subacute, because they only take 50% or less on the ventilator, because 70% connotates that there's some kind of instability going on. So he said, and I don't mean to disparage the physician, but he did say, I didn't realize that he was still on 70%, which he had been on 70% for months. So he told me, go ahead and, turn the FiO2 down to 50. I did ask him, can we do that over the next day or so? Because I didn't want any abrupt changes to cause any further deterioration. He said, fine, you can work with the respiratory therapist. So we did that in about a day and a half. He was on completely stable on 50%. So the second discharge barrier I noticed was, why is he getting blood transfusions every 3 days? Because I know, in hemodialysis, there's a chronic loss of blood over a period of like 2 to 3 months, where, in the tubing, the red blood cells are broken down. So hemodialysis patients do need blood transfusions about every, 3 months. Some can go for 4 months, whatever. So I went to the attending and I discussed the case with him. And at first he said, well, that blood loss is related to hemodialysis. And I was like, well, I mean, not every 3 days, because, that's an acute sign of acute bleeding. So I said, would you mind if I got a GI consult? And they did a GI consult. He had some bleeding ulcers they cauterized. We waited another 2 or 3 days to make sure he was stable. So within about or less than a week, with this patient sitting there for over 280 days because they couldn't get him into a subacute, he was successfully transferred to a subacute. Now, that case, they had already lost over $1.5 million for him sitting there for that long. So that's just an example. Within the 16 weeks, I got all of those 35 cases out. The hospital was so shocked that they sent their corporate down to meet me, which I thought was really kind of ridiculous, because it's like, well, that's just case management. So, it just shows you that, every case manager that they had for those 280 days could have done that with, interacting with the physician, et cetera. So that's just a small example of the value of, and each of these patients, it was hundreds of thousands and millions of dollars that the small hospital had been losing.
It's shocking the amount of waste in cases such as these and how important clinical management is. Now, we haven't really talked about the discharge planning responsibilities of hospital case managers. Can you delve into that?
Yes, I can. That is a very important aspect of hospital and insurer case management. I'll start from the hospital side. That, as a hospital case manager, we always like to interview our patients and their families within 24 hours of arrival to start that discharge planning. And from that point on, actually, what I usually like to do is every 2 to 3 days, I would approach them again and say, has anything changed? And we, spend time discussing with the patient and family any anticipated discharge needs. If they've had a hip replacement and they live in an apartment where there's 35 steps, we have to anticipate that they're probably going to need to stay with a family member, or if they don't, go to a skilled nursing facility short term. So things like that, what durable medical equipment they might need. And then, placing patients into post-acute beds and shelters, that's a huge, colossal juggling act, which it as the hospital case manager, being busy with not only working with the patients and, those reviews I was telling you about, and trying to work with the doctors on the clinical. When your patient's ready to discharge, you have to coordinate this with the support staff person. And hospitals sometimes have 15 to 20 staff, and they're non-clinical, and they're tasked with making phone calls to try to find appropriate facilities and open beds. Also to place in home health care, and order the durable medical equipment. And the sad thing is again, with a lot of case managers, they get more absorbed with doing those reviews to send to the insurance company. They tell their support staff person, hey, I need a SNF, skilled nursing bed, for this patient. And then they don't go back. Personally, I would go back every two hours or so and say, well, how's that going? Were you able to find a bed? And if they weren't able to find a bed, then I would jump in and start making those phone calls myself. And like I said, it's a huge juggling act, a very inefficient process. The other thing is, a lot of times I would take over from another case manager, and they'd The support staff person would be working on, placing the patient in a skilled nursing facility, and they can't get any, skilled nursing to accept the patient. Mm-hmm. And then when I go in and do an assessment, the patient is in 4-point restraints, completely agitated, screaming at the top of their lungs. And, the patient had been sitting there like that for over a week or so, and no one had reevaluated that patient. That patient's not acceptable for a SNF or skilled nursing level. So again, going back to the discharge barriers, would work with either the pain management or the psych doctor to try to get their agitation under control, et cetera. But I'm like, well, for the last week and a half, you've still been trying to get this patient into a SNF, which is an acronym for skilled nursing facility. And they, no one bothered to go back in and reevaluate the patient.
Reflecting on our previous discussions where we touched upon avoidable inpatient stays, how do these challenges impact hospitals, insurers, and ultimately healthcare consumers?
That's an important question, Megan. Air quotations, bad case management directly affects every American financially. Unpaid medical bills are the number one cause of consumer bankruptcy in the U.S., and the way case management plays into that is in several different areas. One being what we call surprise billing, when a patient shows up at a hospital and neither the patient or the hospital knows that the plan is out of network. And also, the insurer sometimes is not notified in a timely manner, so the insurer is not aware that the patient is sitting there out of network. And the financial repercussions of that is the fact that their plan might cover 100% in network, but will only cover 40 to 60% out of network, which can actually be hundreds of thousands of dollars. And a good case manager, which although it's because there's actually not a process to notify everyone at once that the plan is out of network. And that's what, in MidScan, that's one of the 7 modules that we created, is actually a tool that as soon as a patient walks into a hospital and scans the QR code, it lets them know it's out of network, and also repatriates them. You can send a request to an appropriate hospital and get them transferred out, not in days, but actually straight from the emergency room, to avoid those kinds of costs to the patient, who will be billed for the extra percentages that their insurance doesn't pay. Another issue of case management gone wrong is that, like we just spoke about, where a patient is sitting there for days at a time, and the patient has no idea that they are being denied by the insurance company. And as I said before, being that insurer case manager and seeing that sometimes a day later I get the reviews, or sometimes a week later, and I'm just, like I said, I'm screaming inside of myself, get the patient out, because the hospital's losing money. They're not going to get paid. And like I was saying, that they'll lose $3,000 to $4,000 a day on a med-surg patient. And this is per patient, per day, $3,000 to $4,000. Telemetry, it's $4,000 to $6,000, and for intensive care, it's up to $12,000 a day that the hospital is losing, and that they will turn around and bill the patient. I've seen patients go bankrupt, literally go bankrupt over this. So again, sometimes I feel like a lot of hospital executives are not aware of the flaws in their case management that allow these kinds of costs and losses to continue.
So your 7 interlinking software modules actually target the costly inefficiencies related to case management and/or utilization management. Could you elaborate on how the Transpedite application revolutionizes the discharge placement process and significantly decreases avoidable discharge delays?
Yes, Transpedite is a very exciting application, what I like to call new generation, because the current methods, or what were called solutions, is basically faxing raw medical records indiscriminately to multiple post-acutes and home health agencies, and relies on a lot of support staff. And again, if you have to provide a lot of supervision to that non-clinical staff, or again, your patients will be sitting there for days and weeks. Again, we looked at outside industries' use of successful and efficient use of technology such as Trivago, Expedia, Amazon, and Uber, and wondered why healthcare was not using that kind of technology. First of all, there's nothing in healthcare where there's a unified platform where everyone involved in the care of the patient and or the processes regarding the patient, and, for example, identifying discharge barriers or moving them out of the hospital in an efficient manner. So that's the first thing we did. Was our applications are what we like to call freestanding, no integration. It uses 3 or 4 levels of security that exceed industry standards, where everyone, and when we're talking about the discharge process, it would be the hospitals, the physicians, the insurers, for example, insurer case managers, the ambulances, and the durable medical equipment, and the patient and family are actually all on that unified platform and can interact in real time as care is happening. So that's the first exciting thing about what we've created. And these are patented. This system is patented. So we took a look at this discharge placement process and thought, well, why can't we can go on Trivago and order a hotel room with 2 beds, a jacuzzi, no smoking, that has a free breakfast, and we can get that secured or reserve that within minutes. Whereas to reserve an appropriate level post-acute bed and an available bed that's appropriate can take days and weeks. So we automated that whole process where you don't need, all of those support staff people. You don't need to rely on case managers who aren't focusing on clinical issues and working with their support staff people, because this is actually the post-acutes put their beds in real time on the system, and the interaction between all of these entities, you can get the patient out within minutes, actually, or have them a bed claim within minutes, and with automated authorizations, and book an ambulance just like you would book an Uber, and durable medical equipment just like you would buy something on Amazon. So it's pretty futuristic for the healthcare industry. The other thing that's even more exciting is the fact that we have an AI-like technology that when a hospital case manager puts a 2 to 3 minute referral on the system with clinical information, like are they trach vented, what percentage of FiO2, how many IV antibiotics do they have, do they have a wound vac, are they agitated, etc. Are they on hemodialysis? So when our system, if there's no interest from any of the post-acutes, our AI-like technology scans that clinical information and makes that discharge barrier list. Just like I was telling you in that small LA community hospital, in that each patient had a list like that, an expert clinical list of things that needed to be working with the physician, obviously, things that needed to be improved or changed in order to get that patient out. And that system really works. So again, that is an extremely exciting aspect of the technology that we've created.
Thank you for sharing your insights, Rachel. It's evident that enhancing case management efficiency is crucial for improving patient outcomes and reducing financial risks. That concludes our discussion today. Join us next time as we delve into the topic of waste in healthcare and explore Med-Rok Systems' innovative solutions for surprise billing. Thank you so much, Rachel.
Well, thank you, Megan. My pleasure.